Hi, this is Dr. Surapaneni. The topic for today is depression. Depression is a major mental health illness. It's very prevalent in our society. Over 10 million US adults suffer from depression. Depression can be debilitating. Feelings of sadness, lack of motivation can interfere with day-to-day life. Scientists think depression originates due to malfunctioning limbic system, which is a deep part of your brain. Includes the hippocampus, the thalamus, amygdala. Depression is known to be related to a chemical imbalance in your brain, which can result in symptoms of depression. There have been many studies published in medical literature arguing both nature and nurture as contributory factors for depression, but a lot of scientists agree that you need a combination of both to increase the risk of depression in a person. But a predisposing risk through genetics can certainly increase your odds of being more vulnerable to depression. Non-genetic risk factors like poor socioeconomic status, being raised by a single parent, chronic psychological stress, being exposed to abuse, both physically or psychologically or sexually, have shown to be directly correlated to increased risk of depression. A depressed person can experience symptoms like sadness, unable to fall asleep, irritable, anxious, agitated, suffer from appetite loss, lack motivation, unable to concentrate, feel disengaged, feelings of guilt, self-doubt, thoughts of hurting self, unexplained aches and weakness. Suicide is the second leading cause of death for a population ages 15 to 24 years old. We know depression affects women more than men and has a significant impact in the lives of young adults. The slide you're looking at shows you a mood spectrum where a person's symptoms can range from psychotic depression to psychotic mania. Psychotic depression refers to someone who's experiencing hallucinations, delusions associated with depressive symptoms, and then depression obviously reflects depressive symptoms like we talked earlier. Dysthymia is when you have depression for over 2 years. And going over to the other side, from being stable to hypomania, where a person can have elevated mood for a certain amount of time, transitioning into mania, which is a combination of elevated mood, symptoms of feeling euphoric, pressured speech, talkative, goal-oriented, someone who you see gambling away their money, and then transitioning to psychotic mania, where mania is associated with psychotic symptoms like hallucinations and delusions. For the purpose of our discussion, we'll focus our attention on depression and also distinguishing depression from depression with mania. So let's talk about what is a major depressive disorder. A major depressive disorder is defined by having symptoms of depressed mood, like we talked about earlier, feeling sad, fatigued, lack of self-esteem, unable to concentrate, sleeping disturbances, poor appetite or weight gain, recurrent thoughts about death and suicidal ideation for 2 weeks. The assumption is that patients suffering from these depressive symptoms nearly every day for 2 weeks in order to qualify for a major depressive episode diagnosis. In contrast, a person who has depressive mania or bipolar disorder has the features of depressive disorder like we just talked about, in addition to symptoms of mania, which can be the opposite of depression. Essentially, a person may feel euphoric, they're very goal-oriented, talkative, pressured speech, they may need very little sleep. These symptoms need to last for a week in order to qualify for a manic episode diagnosis. There are really two types of bipolar disorders, type 1 and type 2. Type 1 is mostly defined by having a full-blown manic episode. The symptoms that we discussed need to last for up to a week, can involve depressive symptoms. Not all bipolar type 1 patients experience depressive symptoms with mania. Type 2 needs to include depressive symptoms along with hypomania, which is kind of a milder form of mania and does not last up to a week. Some pharmacological treatments that are considered to be first-line drugs for depression include SSRIs like sertraline, fluoxetine, SNRIs like Effexor, tricyclic antidepressants like imipramine, and you have the atypicals like the bupropion or Wellbutrin, and then the old-school drugs like MAOIs, which have fallen out of favor. We understand that neurons communicate with each other via chemicals like serotonin, which has often been associated with happiness. The chemical imbalance observed in depressive patients tend to correlate to abnormal relationship with serotonin chemical in their brains. So by inhibiting these receptors, we essentially elevate the level of serotonin in a patient. Some common side effects of SSRIs include nausea, diarrhea, dry mouth, dizziness. The only SSRI that was approved for use in children under age 12 was Prozac. Zoloft is the most common prescribed SSRI in pregnant patients. Paxil or paroxetine has been associated with weight gain, is often implicated in pregnancy-related complications, therefore assigned category D and should not be used in pregnancy. Celexa has been commonly used for anxiety control along with depression. Lexapro is one of the newer SSRIs, which has a good tolerability profile with fewer side effects. All SSRIs can cause side effects like sexual dysfunction, especially in men with low sex drive, but Zoloft is more commonly associated with sexual side effects. SSRIs have a black box warning for increased risk of suicide in patients 24 and younger. Two other complications that have been reported with SSRIs include stomach bleeding and low sodium in the blood. SNRIs like venlafaxine, duloxetine should not be used in pregnancy due to risk of birth defects. They've been associated with low sex drive, delayed ejaculation, weight gain, elevated blood pressures, diarrhea, nausea, dizziness. They somewhat share the same side effect profile as SSRIs, so it can also cause bleeding and low sodium in your blood. SSRIs and SNRIs have been associated with bleeding complications. There's been many studies that show patients are at higher risk of bleeding if they're taking these medications along with other blood thinners like aspirin, non-steroidals like ibuprofen, naproxen, or blood thinners like warfarin, and the newer blood thinners. The risk is usually due to the fact that there's reduction in serotonin and platelets. Patients who are on these medications are prone to bleeding in instances where they have other blood thinners on board because platelets lose their ability to aggregate or form a thrombus when they have increased risk of bleeding. Let's just say they have an ulcer that's bleeding. They're not able to clot as well because there's reduction in serotonin in platelets, which is primarily responsible for inducing platelet aggregation. A general good practice is for physicians to review medications that patients are taking and avoid SSRIs or SNRIs in patients who are actively bleeding or taking other blood thinners, and also stop these medications preoperatively or intraoperatively to decrease bleeding risk during surgery or post-surgery. Tricyclic antidepressants like imipramine, nortriptyline, and desipramine have been associated with weight gain, dry mouth, orthostatic hypotension, irregular heartbeat, arrhythmias, increased risk of seizures in someone who has a higher risk of seizures. One interesting side effect is drowsiness and can be used as a drug for insomnia. Other side effects include changes in your vision, tachycardia, again, or irregular heart rate, having some urinary retention. These side effects tend to be more common with medications like doxepin, amitriptyline, and from a risk standpoint, desipramine and nortriptyline tend to be the most well-tolerated tricyclic antidepressants. The thing to know about bupropion is the risk of seizures, especially in patients who are prone to seizures. So someone who's been diagnosed with epilepsy or recently suffered a head injury and is more likely to have a seizure or withdrawing from alcohol. The relationship between bupropion and seizures tend to be dose related. So if you take higher doses of bupropion, usually greater than 450 milligrams per day, then the risk goes up. Bupropion can suppress your appetite, result in weight loss, has been associated with increased sex drive or making a person hypersexual. Another thing to remember about bupropion, when combined with SSRIs like sertraline, Selective, Lexapro, there's an increased risk of seizures due to drug interaction potential and can also make a person more tremulous and anxious due to drug-drug interaction. Bupropion under the name Zyban was approved in 1997 to help patients quit tobacco. It's one of the drugs that we use to help patients manage nicotine addiction. Along with pharmacotherapy, psychotherapy by a psychologist is extremely effective in managing mood disorders like depression, anxiety. A technique that they use called cognitive behavioral therapy, as the name implies. They try to modify moods and thoughts into something positive, build more constructive coping mechanisms to help cope and overcome their current mood disorder. In the words of C.S. Lewis, the famous British writer, quote, "Mental pain is less dramatic than physical pain, but it is more common and also more hard to bear. The frequent attempt to conceal mental pain increases the burden. It is easier to say, quote, 'My tooth is aching,' end of quote, than to say, quote, 'My heart is broken,' end of quote." My final takeaway: depression is a serious illness, needs medical attention and nurturing.